Good morning, everyone. Welcome. It is such a pleasure to welcome everyone on behalf of Michigan China Forum. And my name is Ellimoottil, and I am the director of healthcare panel today. And so for our new audiences, Michigan China Forum is a student organization registered at University of Michigan, and we're aiming at connecting Michigan and China and empowering the next generation young leaders. And so Michigan China Forum Annual Summit 2021 is actually consisted of 5 different panels. And so today is our last panel. The 5 panels are culture media panel, automotive panel, and business panel, and US-China relationship panel. So feel free to scan the QR code here at the right corner to visit our YouTube playlist. And for today's panel, we're going to discuss the digital health solutions post-pandemic. So what we are trying to discuss today is mainly focusing on the impact of COVID-19 on the digital health surge, and how the digital healthcare technology has been integrated into the ordinary people's life in both US and China, and also how much potential it can be unleashed in the future. Unfortunately, and also we are offering the simultaneous interpretation here, and please click the button for the simultaneous interpretation. And I'm gonna repeat that in Chinese. 请点击右下角此按钮开启中文同传 for our Chinese speakers. Unfortunately, our moderator today hasn't joined us today because of some technical issues and etc. So let me introduce our panelists today. So first of all, let's welcome Dr. Ellimoottil. He is a director of Telehealth Research Incubator at University of Michigan. He is also an assistant professor and the director of Telehealth Department of Urology at Michigan Medicine. And Ms. Ting Shih, she is a CEO and co-founder at ClickMedix. She's a prominent woman leader in the healthcare technology, and she's such an inspiring entrepreneur. And let's welcome Mr. Jamey Edwards. He is the CEO and founder at ClouDr Health. He's a serial entrepreneur and has an aiming at humanizing and fixing healthcare. And last but not least, Mr. Kuang Ming, and he's a CEO and co-founder at ClouDr, and he's basically China-based, and it's very appreciated that he's joining us from China at 9 p.m. So I think we can let's start our event with a keynote speech, thankfully delivered by Dr. Ellimoottil.
Thanks so much. And thank you for the opportunity to present today. I'll be talking about digital health solutions in the post-pandemic world, and I'm super excited for the panel that we have lined up today. Just a little bit about myself. I view telehealth and digital health from multiple different perspectives. From the clinical perspective, I've been performing video consultations with my patients since about 2016. On the operations side, I've helped our program grow. On the research side, I conduct research on the population level impact of telehealth on cost, quality, access, and the patient experience. And then finally, I try to take our research and bring it to stakeholders so that we could actually have informed policymaking. And so with these perspectives, I'll give you an overview of telehealth in these three areas. One is what is telehealth, or what is digital health before and during the pandemic. And then I'll finally talk and give you some conceptual models on how telehealth can either improve or worsen access, costs, and quality. So to begin with, what is digital health? So digital health is the use of remote technology to diagnose, to treat, and manage disease. And so it's a paradigm shift from how healthcare was primarily delivered in an office, and all content and medical content was delivered during that visit. And it's moving that visit to other types of technology, like using a smartphone, using a tablet, using a laptop. And that's what telehealth, that's what digital health is. These terms, virtual care, telehealth, telemedicine, digital health, are all, for all intents and purposes, are really the same thing. And I'll use them interchangeably during this talk. So lots of different forms of telecommunications technology can be used to deliver healthcare. And so when we think about the different categories of digital health, I think it's important to sort of think about these big divisions. So one way of thinking about digital health is, who is the digital health provider? There's been a big growth in what are called direct-to-consumer models, where national companies are partnering with insurance companies and also with employers to provide healthcare directly to patients, or providing that care directly to patients, and really circumventing the healthcare system altogether. That's been growing very rapidly, even prior to the pandemic, but certainly now. And then now there's also a lot of healthcare practices that are offering digital extensions, offering video consultations, and other ways of connecting with patients. So both these areas are growing very rapidly. You can also think of digital health solutions and how the care is delivered. So there's synchronous, where the interactions are live, and then there's also asynchronous. So asynchronous, perfect example of that is taking a photo of a rash and sending it to a healthcare provider. The healthcare provider looks at that and can give you a prescription for it, and that's asynchronous telehealth. And then the third big category is what the technology is doing. So is the technology making healthcare more convenient, or is the technology actually providing new information to the patient and new information to the healthcare provider? In terms of making care more convenient, video visits, telephone, portal messaging, patient portal messaging, these are all forms of telehealth that make care more convenient. Remote monitoring, wearables, and a lot of the mHealth smartphone applications are actually creating new information for healthcare providers and for patients. So what's happened with digital health before and during the COVID-19 pandemic? To understand that, I think it's important, at least in the United States, to understand the history of how telehealth has been viewed and regulated in the United States. Medicare program, which is the largest payer in the US, it's for patients that are disabled, have end-stage renal disease, or are over 65. They actually were covering telehealth and reimbursing healthcare providers for about 20 years, but it never really took off because there was a lot of tight regulation around how telehealth could be delivered. Specifically, that telehealth had to be the patient had to be in a rural area, and they had to be in a medical facility. They couldn't do it from home. They couldn't connect from home. And that was the big regulation that really held back telehealth for many years. In recent years in the United States, there was a lot of momentum to move some of this care to digital forms. The big payers like Medicare and Medicaid, which is for low-income people in the United States, started to relax their rules and became more and more telehealth friendly. But what's really important to understand is that in the United States, in February of 2020, less than 1% of healthcare providers in this country and less than 1% of healthcare providers ever used any formal digital health or telehealth with their healthcare providers, less than 1% at that time. And then in March 2020, everything changed. That's when the coronavirus became a big deal in the United States. And because of the need for social distancing, and also coupled with major regulatory reforms that occurred in March 2020, telehealth did grow. These regulatory reforms included allowing patients to connect from home, reimbursement changed, providers were able to practice across state lines, and a lot of privacy rules were relaxed. So it was the combination of these major regulations or deregulation that occurred in March, and plus this need for social distancing that caused telehealth in the United States to grow. And that's exactly what happened. And so this is data using Epic, which is a national electronic medical record. And these data is showing outpatient visits and what happened during the months of March through July 2020. What you can see is that the purple line represents total visits. And from March to April, there was a big drop. 60 to 70% of total visits dropped. In-person visits, which is represented by blue, dropped significantly. And then telehealth, which was below less than 1% in February 2020, started to grow. Telehealth never really reached the levels of pre-pandemic total care, but it did provide and salvage some of the care during the months of March, April, and May. And then as we moved on from May, you can see that a lot of in-person care, it became safer to go see your healthcare provider, to go see your doctor. And so a lot of in-person care started to grow, and telehealth tapered off a little bit. But right now, even in the months of July, and we have data in September from insurers, from Insure in Michigan, it's still at about 20%. So in the United States right now, I would say on average, 1 in 5 healthcare encounters are through telehealth currently. And that's across all different specialties. And this is a list of specialties at Michigan Medicine. And you can see that there's some specialties that adopted telehealth a lot more than other specialties. Like in orthopedic surgery, even in fields like orthopedic surgery, at least 15% of these visits are being done virtually right now. Of course, in mental health, this is where telehealth has really become used a lot, and COVID has really changed the delivery of mental health services permanently, I believe. And I'm not going to speak so much about the market right now because I think a lot of our panel will talk about this, and our panel is full of experts in this industry, but we do know that there's been a big boom in the growth of funding opportunities and growth of digital health companies over the last few years, especially. And investors seem very confident that this is going to continue to be really a permanent thing. This is stock prices for Teledoc, one big telehealth company in the United States, and you can see that their stock prices were continuing to grow far into 2020 and into 2021 because of the confidence that they had in the growth of telehealth. And many policymakers have signaled the same thing. This is the former head of the Medicare program, and she really helped spearhead a lot of the changes that happened during COVID. And this is what she said publicly, that it's very hard to imagine that we would ever go back to a time where telehealth wasn't a big part of healthcare delivery. But with that said, there's still a lot of federal policies and state policies that still need to get worked out. I've bullet pointed a few of these big policies. Most people would argue that telehealth is here to stay. Digital health is here to stay. And on both sides of the aisle, people want to make this permanent. It will become permanent, the changes, but the final shape and form is still being debated. Issues like whether or not you should be allowed to practice telehealth, or providers should be allowed to practice telehealth across state lines. How much should you pay for it? These are the issues that are still being worked out. But in general, there's no doubt that there will be telehealth continuing after the public health emergency is over. The part that we don't know so much about is what impact this is going to have at a population level. This was a letter that was written by 30 senators to the to the leaders of the Senate. And essentially what they were saying here is that we don't have a lot of data. We need to get this data on how this expansion of digital health is going to improve healthcare utilization, quality, outcomes, healthcare spending. And that's going to be really important. We never had such a scaled growth of telehealth before. And so this is really the unknown frontiers. And this is kind of especially where my research lab focuses, the Telehealth Research Incubator. And we're really focused on the population level of impact of telehealth on healthcare access, quality, costs, and the patient experience. And I'm not going to go through our research findings right now. I'll talk about them certainly during the panel. But what I do have to say is that these issues are not straightforward. There's a lot of complexity to it. one could say that telehealth, is easy. It improves healthcare access, but really when you dig down, the healthcare access itself is not that simple. There's a lot of different layers to it. In order for telehealth to improve healthcare access and improve healthcare outcomes, it needs to be affordable. Can the patients pay for it, or can the patients afford it? Can healthcare providers afford to offer it? Is it available when a patient needs it for the type of care that they need? Is it available? Is it accessible? Does it accommodate for the patient's preferences, and do patients view it as acceptable? And so these are the 5 A's of access, and the relationship between telehealth and these 5 A's is actually very complex. And we can certainly talk about some research in this area of healthcare access. In healthcare spending, when you think about the impact of telehealth and digital health on healthcare spending, there's kind of 3 perspectives that you need to think about: the patient's perspective, the provider's perspective, and then the payer, like the Medicare program, for example. And within these 3 buckets, there are arguments as to why costs for all 3 of these buckets can increase with the growth and expansion of digital health. And there's also very valid arguments as to how costs can decrease too. And so the true verdict is still out there. It's yet to be seen, but I think this is ripe for research for us to understand truly the impact of telehealth and digital health on healthcare spending. And the same goes for quality too. And it's not the technology that actually produces quality at all. It's really about what is the underlying mechanism of the technology that can improve quality and potentially improve clinical outcomes. Does the technology make it easier to access a healthcare provider? Does it improve the frequency of patient healthcare provider interactions? Does it allow self-management? These are some of the things that we can think about when we assess a technology and try to understand whether it's actually going to improve clinical outcomes. But again, that relationship is not straightforward. So I'll leave you with a quote, one of my favorite, because it really embodies what technology can potentially do for this society and what telehealth and digital health can do for this society. Technology is really capable of doing great things, but it itself doesn't want to do great things, that it doesn't want anything. That part takes all of us, and it really involves the use of the understanding what technology can be used, the proper use, the clinically appropriate use of it, the innovation before it can actually do and really make a disruption in U.S. healthcare. Thanks so much. And feel free to reach out to me if you're interested in connecting or talking more about this topic.
Thank you, Dr. Ellimoottil. That is a really insightful keynote speech. And I'm sorry that we're still missing Mr. Hong right now. So we really appreciate Dr. Ellimoottil to lead the discussion today. And I'm gonna pass it over to Dr. Ellimoottil now.
Sure, absolutely. No problem at all. I know how these events sometimes go, so don't worry about it. And yeah, I'm happy to lead the discussion. I felt like it was like my body double giving that speech. I actually wore the same clothes because I thought it was smoother, but then I was up on the screen during that, so I got caught. But yeah, no, thanks for allowing me to give that presentation. Just a broad overview. I kind of kept it more focused on the policy side because we have our experts here today to talk a lot about the market, which I'm super interested in. And I know that on both sides, from the US and from China, there's a lot of interest in the market part of this. So we'll definitely dig into it. I think probably the best thing, if helpful, would be for us if each person can sort of just introduce themselves and talk about the company and maybe a little bit about their story of how did this idea lead into this, major successful organizations that you 3 run right now. And that it would be great to hear from all 3 of you. So Ting, do you want to start?
Sure. Hi, everyone. My name is Ting. I'm the CEO and founder of ClickMedix, which is a company I founded out of grad school at MIT a long time ago. The idea started literally in a classroom, and the problem statement was simply stated as create a business that will impact over 1 billion people. So I'm going to take you back to 2007. Remember, there was no iPhone. There was really no Android smartphone. We're still on these Kit Kat bar phones, the flip phones or the bar phones. However, we knew if we wanted to impact over 1 billion people, it had to be something they can access. And most people, while they may not have electricity or even clean water, they had a phone. Anywhere in the world, there's access to a phone. So we thought to connect doctors from anywhere with phones to patients. And we did a lot of pilots to prove this out. And obviously, we all know it's very effective and it can be done on a phone. We started way out in Botswana and then Egypt, and then realized some of the same problems are in also US. We saw in China as well. Rural people don't really have access to healthcare. There isn't always the funds to pay for healthcare. And the funding for healthcare is different in every country. I'd say us here in the US are probably the most convoluted payment system, layers and layers of different payment. So what we've built is a platform that enables different types of health service providers. So whether it's a hospital or a clinic or insurance company, to provide telehealth services that include a clinical set of questioning of the patients. Because when we first started, we realized if we could get really good information by health worker or even patients themselves on their health condition, all of that data could then be packaged to be reviewed by a medical specialist anywhere in the world to provide the accurate diagnosis, and they'll even provide instructions on treatments. Then we can also tailor those treatments to what is available in the country, and thereby connecting doctors from anywhere and patients from anywhere with the best of medical expertise with very low knowledge of using technology. Everyone knows how to use the phone, and providing the data that's needed. And then, and I can say, Dr. Ellimoottil talked about asynchronous and synchronous communications. Asynchronous, like a photo, it's not a live video. That's just as effective. In fact, we treat about 80-90% of patients that way. And then the video, very, very effective, especially for psychiatric or mental health issues. So a lot of learnings. I'm happy to share more, but very happy to be here and share more about where we're heading post-pandemic with the whole full adoption of telehealth. Thank you.
Great. Thanks for sharing that story. Jamey, do you want to tell your story?
Sure. So I'm actually a previous investment banker and private equity professional who comes from a family of doctors. And so my sister's a doctor, aunts and uncles on both sides are doctors. And so grew up in and around healthcare. And I started off actually my entrepreneurial journey in managing a family business, which was an ER hospice and anesthesia group in Southern California called Emergent Medical Associates. Ended up growing that group to one of the leading groups in the Southwest. And while I was doing that, came across a company called the Language Access Network, which was founded in 2003 by a gentleman named Andy Panos. And Andy founded the business because he was in Mexico and was in a car accident, and no one spoke the language. And, the problems ensued, and realizing that communication is the number one diagnostic tool that a doctor has. If you look at a patient chart today here in the United States, it's what's your history of present illness, what's your family history, where does it hurt? A lot of the diagnosis tools that are used, the best one is being able to communicate and explain that if someone comes in clutching their chest, is that a heart attack workup or is that an indigestion workup? Well, the way you get to that is via communication. So he ended up founding a company, coming back to the United States, thinking that this was happening, in a diverse company like the U.S. over and over again, and began to discover that in his hometown of Columbus, Ohio, there were 126 different languages spoken in that city alone, which I think that number catches people by surprise. There are refugee settlement areas all over the United States. There are more. The U.S. is becoming more and more diverse by the day, and as a result, being able to deliver healthcare to all of those constituents became a real challenge and a real healthcare disparity. It turns out that people whose language was, in homes where they primarily spoke a language other than English, which is kind of 1 in 5 U.S. homes, that those patients tended to languish in the hospital for longer. They weren't seen as quickly. They had to wait for interpreter resources to arrive on site, et cetera. So the Language Access Network's mission was to really solve that. I ended up getting involved with the company in 2008, and then redefining the business as a healthcare disparities solutions business. And we proceeded to grow the business. And we're in 1,800 hospitals today, doing over 100,000 encounters a month over the platform, offered in over 250 languages, over what are 14,000 plus video endpoints in the field. And our hospitals started to really ask us to do more. They realized that these LEP and deaf patients were throughout every hospital department. And what most people don't realize is the teleinterpretation, telemedicine use case is the most popular use case in hospitals in terms of usage. It's used more than telepsych, it's used more than telestroke, it's used more than tele-ICU. So given the sheer breadth and depth of the service offering and the fact that these LEP and deaf patients were in every hospital department, people realized our platform, therefore, was everywhere. And we started to launch new use cases on the platform, like telepsychiatry and telestroke. During COVID, we launched telequarantine, which allowed our devices to be rolled into the room and turned any hospital room into a connected care room so that the doctor didn't need to go into the room, reduced the risk of exposure. It reduced the use of PPE, which at that time was a very scarce resource. And it also reduced the isolation that the patient felt at the point of care. Everyone talked about COVID being a very lonely diagnosis because your family couldn't come see you, et cetera. So we built in a HIPAA compliant way for patients to speak to family members and for family members to be involved in care decisions with the hospital and the provider, et cetera. So that's kind of where we sit today. We're in the process of merging into a larger business called UpHealth as part of a SPAC. As people in the United States may be experiencing, the SPAC market has become very popular as a way to finance businesses. And so we're excited to write the next chapter of CloudBreak as part of a broader organization really supporting local healthcare in addressing social determinants.
Great. Thanks so much, Jamey, for that inspirational story. Ming, do you want to sort of introduce yourself and then tell us your story?
Sure, no problem. So, okay, I'm very happy to participate in this forum this time. So my name is Ming Kwong, and CEO and founder of the ClouDr. Actually, my background is different from everybody. I'm a mixed background between the technology and the healthcare. So, I graduate from Jiao University in China and Cambridge, UK. My major is electronic engineering. So my first job was in Intel. It's different from, the traditional, the traditional healthcare. So as my job is programmer. Have a lot of coding work in firmware and something like that. But after that, in 2010, I switched my career to join Johnson & Johnson Medical. So at that time, I switched to work in US and actually in the New Jersey as a R&D and marketing, focus on the R&D for medicine and for medical device. Okay, this is my first time to access the healthcare sector, and I'm really interested in this sector very much, and I see a lot. I visit a lot of hospitals. in US and in Europe. Okay, so I worked in US for several years, and after that I came back to China, and I found one thing, here. As I mentioned, in China, there's so many population have the problem in chronic condition. Actually, here, over 500 million population has an issue. The chronic condition, for example, the diabetic patients or high blood pressure or cardiovascular or something like that. Over 500 million. So many people there. But actually, our here, the medical service and the resource is very limited compared with the US. Even the ecosystem is very limited. So that's why I have an idea. Here the demand is so huge, but the resource, the supply is limited. So this is a very good opportunity for us to improve the efficiency, or improve the efficiency and with the technology to give more accuracy and more efficiency to this kind of demand. So this is a very, very quick idea. So that's why in 2014, with friends and other colleagues, we set up this company, ClouDr. I mean, actually, our company is a SaaS-based digital platform for chronic condition management. With this system, because our system already covered 20% hospital in China, we can connect them, and 25% of pharmacy. So, which means every chronic condition patient can be very easy to connect doctor in everywhere, in anywhere, at any time, if they have that kind of demand. Very similar to the Teledoc and the Live on Go in the US. Okay, so now the ClouDr is the largest digital platform, online digital platform in chronic condition sector in China. So this is my story. Why we have this kind of idea to set up this company, and our target is to deliver the best healthcare service for chronic condition management to every family, to make them happy. So that's it.
Great. Thanks a lot. So thanks for those introductions. So one of the things I'd like to talk about is just about specialty use. So you mentioned, Ming, that primarily you've been using this for chronic conditions. We've seen a lot of digital health even prior to the pandemic being used for chronic conditions. So one of the things I wanted to ask you, and then we'll go around to all of the other panelists, is beyond chronic conditions, where do you see, especially in China, where do you see your opportunity in other specialties? Where's the big opportunity from a specialty standpoint in your healthcare system? Ming.
Okay, so I think actually, there, in my opinion, because as I mentioned, the demand, not only in chronic condition, but also in other areas, the demand here is very huge because the population in China, a lot of people have that kind of medical service demand. And another thing is, first, with the growth of GDP, so more and more people have higher demand for medical service. They need better service, immediate, better quality. Second, because currently the medical service, the doctor resource is very, very limited. So beyond the chronic condition, we can see other several sectors are very hot. For example, the gene technology. Okay, this is the first thing. And the second, I think the diagnostics are very hard because so many people currently, if we go to the hospital, the first thing is do some diagnostics to support the final decision of the doctor. But that kind of resource is very limited to influence or decrease the efficiency for the treatment. So this is the second thing. The third thing is, the remote China is very big, it's huge. So a lot of rural area, they need the doctor, but the distance is an issue. Okay, so so we believe the remote technology can do a lot of things to help them. Okay, so this kind of sectors, then we can see have the potential to improve the healthcare industries.
Thanks so much. Ting, what about you? What specialties have you primarily focused on, and where do you think the opportunity is from a specialty standpoint?
So go ahead.
Sorry, go ahead. Yeah, no. Go ahead.
Okay, we focus on specialties. Basically, the way our system works is when there is a specialty, everyone has sort of a patient intake form with a set of medical questionnaires. And recall when we started, we were trying to empower a health worker who has no medical knowledge to collect the right data. So it's very apt for that, and particularly in the specialty area, where I think the gap may be currently, if you look at specialties like cardiology or orthopedics or some others, you are quite limited from just having a video conversation with the doctor. Especially if it's a new patient, you do need to do that full physical assessment and all the imaging labs, all of that, to have a complete data set of that patient. I think follow-up is a great opportunity where you already know most about the patient, but you want to check on something, you could do that through video. I think a second really important aspect is really, how can we care for patients the other 364 days you did not see that patient? How do we bring services into the homes? And what we're seeing as opportunistic and already available being done is integrating with devices. So if you have a 6-lead ECG, you could do a lot. You could do probably nearly complete cardiology follow-up without having the patient come all the way in. And more than that, you can monitor them a lot more frequently. And there are also wearables, you can monitor them continuously. And a lot of what we do is equipping any home care agencies with a kit of devices that will connect with the doctors. And then there's another aspect where if you look at the vulnerable population, seniors, or the ones that don't have as much access to really anything, they need some startup or training to even use the phones that they have. So a lot of times we initiate that by having a nurse to help the patient understand how telehealth works and any of the medical equipment, including maybe their everyday blood pressure, how to use that, how to capture that data so that they can be treated and monitored on a continual basis instead of just a single video or even in-person visit. So I think there's, while there's huge adoption in telehealth, I think a lot of practitioners are also realizing there's limitations to it. It's way better than nothing. But if we could bring more equipment or more training to patients themselves, then they can start caring for themselves and initiate those calls and get help when they need it, or even before they need the help, before adverse events. A lot of our focus are on very high cost events, cardiovascular problems. CKD, so chronic kidney disease, is another area that's very apt for telehealth. Even home-based dialysis are becoming more prevalent and monitored remotely. And there's seriously a quite long list of specialties that are great for telehealth, but they need a little more than just a video call and a bit more on the patient training side, which is a great opportunity for US and other countries as well.
Yeah, I can't agree with you more. I think, across our health system, and we've seen some of our specialties that have been slow to adopt even after the pandemic, or they've just kind of gone back to in-person care after the pandemic. It's really because they need something else beyond just the consultation, ear, nose, and throat, for example. The specialists that deal with that in almost every visit, they're doing a scope, and so it's like, if you can't have certain types of ability, then you may end up not being able to provide all the care. But I agree with you. That's certainly a great opportunity. So if you can't necessarily provide that type of care through video, then maybe there's additional digital tools that could be incorporated. So Jamey, I just want to turn to you in terms of specialties. What I know that you've been well adopted in, across all specialties, but what have you personally seen great use cases, and then sort of other specialties that have sort of lagged behind, and how could those specialties change to become more virtual?
Yeah, Chad, look, I think it's really interesting. People tend to forget that digital health was alive and well pre-COVID, right? It was just mainly used in hospital. And it was mainly used because there are a lot of medical deserts that exist across our society here in the US. And people talk about the applications, obviously, of telemedicine and rural telemedicine and being able to bring specialists into those areas. But the fact of the matter is, in some of our nation's biggest cities, we have medical deserts as well. I live in Los Angeles, and not everybody gets to go to Cedars-Sinai. Not everybody gets to go to UCLA. There are small community hospitals that are 10 miles away from those hospitals that don't have the same access to specialists and doctors. And so those community people in those communities tend to have to drive in order to see those specialists. So telemedicine really helped level the playing field and allowed us to load balance the healthcare system here. And there's literally thousands of different use cases. I think it's interesting. It's like when the stethoscope came out, I don't think they referred to it as, hey, I'm going to practice stethoscope medicine. It was merely a tool, right? Yeah. That the doctor used to help make the diagnosis. Digital health tools are simply no different. I think we're going to get to the point where people stop talking about telemedicine as telemedicine or digital health as digital health, and we'll hopefully just talk about them as healthcare and medicine, and they're just the new modality of how we do these things. We have seen that telestroke has been an incredibly effective use case, saving lives millions of times a year across the country. We've seen telepsychiatry be an incredible tool at the point of care in hospital to make sure that these patients don't languish in an emergency room or an inpatient and can be discharged on time and discharged with follow-up. We've seen the language interpretation services use case. We've seen case management. We've seen nurse mentoring. There's are so many different things that can be done when people finally start using the technologies for its purpose. And it's like during COVID, it's not like there was an amazing new technology that was launched that really said, oh, now this is the right time to adopt it. We're using the same technologies we've used for the last 10 years in email, video, chat. And we started to realize that the gold standard is no longer the in-person visit. We still have a whole industry structured around this in-person visit. And that is why largely I think people are regressing, if you will, to going back to a lot of, hey, come meet me in the office. I'd like to put hands on body. One, I think there is a clinical imperative for it for certain specialties. You mentioned ear, nose, and throat. There are just certain specialties where, having hands on body is important, but there are other ones that are much more consultative from a neurology standpoint where you're looking at films. Like a lot of that stuff can be handled remotely. And so, from my standpoint, until reimbursement and some of these other structural issues come up, they're starting to build hospitals smaller here in the US as a result of things like telemedicine, more ambulatory visits, and people wanting to keep patients out of the hospital, not in the hospital. And with a movement to value-based care, I think you're going to see a lot more of people using things like telemedicine to keep patients out of the hospital. And specialties are a great way to do that. We're even seeing, tele-oncology. We're seeing teledietitian, all sorts of different things. As we're taking a more global view of what we'll call whole person care, you're seeing a lot more telemedicine and a lot more of these specialties. So personally, I'm really excited to see the newer use cases and the edge use cases start to become more mainstream. And a lot of the things that we used to have to get in the car and drive to the office, take 3 hours out of our day for a 15-minute visit, see a lot of efficiency come to the system through, those types of things.
Great. Thanks a lot. And so, Jamey, I want to start with you for the next question. I think, just going back to what you said earlier, that, it wasn't COVID that made all these technologies develop. They existed before, but the pandemic really accelerated things, largely because of the need for social distancing, but also combined with a lot of regulatory changes, reimbursement changes. And so, I talked about some of those in the talk, but I'm curious to know from your perspective, and I want to go, so we have a unique set of perspectives where, Jamey in the US, Ming in China, but then Ting also using technology in other countries too, to be able to draw that comparison. So I wanted to ask everyone, how has the healthcare infrastructure either been a facilitator or a barrier to your company's growth?
Yeah, I go back to that comment about the in-person visit being stressed here, and I would love to hear kind of Ting's perspective on this in a second, because what we've seen, and as we're merging into UpHealth, one of the companies is an Indian telemedicine company called Glocal, and they have really redefined kind of this hybrid encounter where they have an 8x8 kiosk that can be dropped into any emerging market. And it's staffed by a lower level healthcare worker, and then they beam in the doctor, and they have point of care testing, and they have point of care digital diagnostics, as well as medical formulary on site. And so it's a very low cost way to provide primary and specialty care. And what we've seen in emerging market countries, and we saw this as a comparison with cellular services and wireline services. In the United States, it took us a lot longer to adopt cellular technology than some of these emerging markets, because we were fighting the existing revenue base and the existing infrastructure that we had already built out here in the US in terms of wireline. And what we saw in emerging markets is they had a much more robust cellular infrastructure much more quickly because it was helping solve a real problem for them. And so those countries adopted those things much more quickly. I think we're going to see the same thing in digital health when it comes to a digital first healthcare system. Because if you were going to rip down the US system and rebuild it today, you would rebuild it differently. We'd have, the initial digital front door would be how we get access to the healthcare system, and then it would guide you to the right stage of care so we can match cost to acuity of resources and do those types of things. And so we've seen emerging markets almost leapfrog the US healthcare system in terms of digital applications. And here in the US, we're still fighting a little bit of our regulatory policy. We're fighting our privacy issues. I go back to, there's a woman named Stacy Hurt, was a colon rectal cancer patient who's on Twitter, who has made it very obvious that a lot of hospitals and healthcare systems today simply have not adopted the technologies they need to have to make the care encounter less friction, have less friction. And by that, I mean, she was trying to get her patient record and it was still issued to her on a CD-ROM. She does not have a CD-ROM to even read that patient record, right?
That's so a floppy disk.
Right. You're looking at these and you're like, why are we not doing this and dropping this into, some sort of cloud storage that then can be shared? I mean, those things are here today. So we're fighting a lot of the fact of changing human behavior. What I'll say is technology is not the issue in the healthcare system today. It's human behavior and how you get the structures in place to actually change that human behavior so people don't revert back to what they did before, but they actually adopt the new tools for their stated purpose.
Great. Ming, I was going to ask you next. I was wondering if you can sort of, just because I'm not as familiar with with China's healthcare system, if you can sort of describe how are healthcare providers reimbursed in that system, and then how has that been either a facilitator or barrier to your company's growth?
Okay, so basically give you a very brief introduction about the reimbursement system, because payer is always a god to drive this industry. So basically, according to the data of the last year, 2019, you will see 50% the cost expense covered by the government insurance. It's very different, totally different from the US situation. Okay, 50% covered by the government reimbursement, and the 5% expense covered by the insurance, the commercial insurance. Okay, and another 45% covered by by our pocket, because this is a current payment system in China for the healthcare. For the healthcare industry. So the situation is very different from the US. So which means in the US, basically what we do is how to improve the efficiency, how to save cost, and improve the result. And we can, if we can prove that to the insurance company, then basically to the insurance company and then employers, then basically the business model work very well. Okay, and then we can expand the scope and something like that, and a big success for insurance company, for employer, for employee, and something like that. Okay, this is a situation in US, and actually according to discussion between us and our brother company, our investor portfolio, for example, I think the Lingwang Gold and other, they are a portfolio of our investor as well. According to the discussion, we know the situation in US, but here in China is totally different. Okay, you see only 5% are covered by commercial insurance, which means, okay, they are not major player. Now in the future, we believe there will be the major player because the growth is very, very fast. Every year, I think in the past several years, we noticed the CAGR of the commercial insurance is over 50%, which means very fast. But now it's not major player. What we do first, we have to please every patient. Let them know the importance and let them know the value of the medical system or even the telemedicine. Okay, they will pay for that. Okay, they will pay for, I mean, either the better result or the better experience. This is the first thing. The second, if we can prove the result and save cost to the government, okay, then we can, win the contract from the government. But I mean, it's very difficult because basically, government is, the government, I mean, the size is very big. So which means they need a very long time to review the process and the result. And once they make sure they can, sign the contract with you. Okay, so this is a difference. Okay, come back to our company, basically. So as a startup company, okay, even we focus on the chronic condition, but we believe telemedicine area is very similar. Okay, we select the first way. I mean, we focus on improving the experience and the result, and we show them to our user, I mean patients. Then we can make money from patient directly and from the employer. Then we can survive and we can expand. Then with several years data and experiment, then we can show this data and the result to the government. And the very good news is from this year we can win some contract. We can win some contract for our government. But you know what? I mean, the revenue of our company in last year is over 1 billion RMB. So which means now we're not so small. That's the basis for a startup to win the contract and the trust from the government. So this is our way. Yeah, just to give you example.
Great. Thanks so much, Ming. So Ting, you have a unique experience where not only has your company grown successfully in the United States, but you mentioned in your story that you started off by looking at other countries too. So I just wanted to know, just from your experience, Ting, what was the what are policies that are in the U.S. that are sort of a hindrance to your growth, especially prior to the pandemic, and how does that compare to other countries that your company's been involved in?
Sure. Bringing back to one of our first deployments in Botswana. And as you know, Botswana, one of their largest exports is diamond. So it's a pretty wealthy country, relatively. And the government pays for all of the healthcare. They pay for flying the doctors to rural areas to treat various conditions. So we started our project there. And obviously, because there wasn't anything like that in places like Botswana, their single dermatologist was imported from the US on a 1 or 2 month stay, and they rotate through doctors in that way. So they have really, really scarce resources of specialist doctors, especially. And we were able to show that you can connect to specialists while they're home in the US and still provide the same care, while at the same time we're training their health workers, nurses, and doctors to do specialty care in this telemedicine mobile health way. Then it was then adopted by the government after we've proven millions of dollars of savings from flying their doctors around and importing doctors. And then they now have an mHealth Institute that focuses on telemedicine and other telehealth initiatives. So that's an example where policies was created because it's needed, and because there's such a benefit, the government was helping along the way, co-creating what needs to be there with the teams. So, and then we actually replicated the same model. We started in teledermatology in the US, working with American Academy of Dermatologists. I mean, you would think that's the best place because all the dermatologists are, most of the really high percentage of dermatologists are all part of that association. So we started a 20-state pilot in the US to see if we can provide care, and we did. However, when it came to and this was a volunteer activity from the dermatologist provided to the free clinics in the US. But when it came to payment and licensure problems, and this is pre-pandemic, a doctor can't be licensed in most states, and the rules constraints against where the patient is, where the doctor is, and do you need a live video or not? In dermatology, you do not need a video to provide an accurate diagnosis. We've proven that over and over. So all of these rules and regulations within the US made it really difficult for a doctor to want to do this in their own private practice, offering to patients who are still driving hours and hours to see some of these specialists. So we saw a really sharp contrast between, the policy that's being created as we are, letting them know, hey, these are the policies that will help expand the program. Where in the US, it's literally, well, cross-state licensure. You have to be licensed in every state, and the patient needs to be in the same state where you are. All these rules, and then reimbursement. Yes, you can do the service. We're not sure if you ever get paid unless you have these codes, and then wait months for, the insurance to recognize it and get paid. So all this hurdle, and I think going back to your slide on the 1% adoption, I mean, obviously the technology works, it's effective, people want to do it, but when doctors don't get paid for their services, it makes adoption really difficult. I do want to share another story, in Pakistan, when one of our programs where most of the payment is private pay, and the way they got our partner there, it's a group of female doctors who are very incentivized to do this as remote work because of various constraints for a woman doctor to have her own practice in Pakistan. And this applies to many, many other countries outside the US as well. And they work with employers to provide telemedicine services at on-site work clinic using our technology. And they do that in rural areas as well for outreach. So there's another example where there aren't really stringent policy constraints. They just don't really exist. They're not reinforced or stopping these activities. But what's fascinating is when the pandemic hit, Pakistan was looking at how can we tighten up our telehealth policy? Every other country is doing it. Now we need to formalize the process, have a policy, and what should we do? So they look to the US on what is the US telemedicine policy? What do we put in our clauses to allow this to happen effectively and safely? So it's really fascinating. It's almost like going round and round. Yeah. And while these countries have fully adopted, but they're looking for the US for the policies and the stringent requirements. Meanwhile, the US, by nature of necessity, had to relax the telemedicine rules so that telemedicine could actually happen and doctors get paid. And you saw that. It's really fascinating, that the single main contribution to that adoption was policy change in the US, allowing doctors to get paid for this type of services and everything else that went around it. So I felt it felt like full circle, starting with, yes, we can do this. There are no laws against it. And okay, now every country has adopted telemedicine in some way as necessarily due to the pandemic. So I think it's the silver lining I see with pandemic, and really excited to have sort of waiting in the wings for some adoption to happen. So it's exciting times.
Great. Well, thank you so much. And it's such a great global perspective that you have on it. So, speaking of telemedicine policy, the primary reason that when policies were when it was deregulated in March, they weren't it was sort of a no-brainer thing to do for the pandemic, but there were commercial insurers in the United States that had relaxed policies over time, but really what everyone was waiting for was Medicare. Medicare is the largest payer in the United States, and so most health systems and so forth were waiting for Medicare to turn the switch, and they could have turned it on, or they could have deregulated a long time ago. But the main reason that there was a lot of hesitancy, there were a lot of bills that were brought up to deregulate telemedicine over the years. But one of the biggest parts of that hesitancy was that the Congressional Budget Office has always scored telemedicine poorly, saying that, that healthcare spending is just going to go up. And I know that all, your companies are working in high impact areas to reduce costs, especially for chronic diseases. But I do wonder, that is also kind of a valid argument too, is that healthcare spending may go off. I mean, may skyrocket because, we're essentially bringing in a lower barrier to entry. And a lot of these companies focus on experience, so it makes it easier for patients, which is great, but then that could also lead to higher utilization. So I'm curious, I'm sure these questions have come up, like how do you respond to policymakers that say that expanding telemedicine, going back to pandemic policies after the pandemic is over, is only going to lead to increased healthcare spending? And so I want to let's start with Ting, and then we'll go to Jamey, and then I want to hear everyone's perspective on it. So Ting, how do you respond to something like that?
So we actually work with the Medicare payer directly, mostly on enabling their nurses to deliver and train patients, as I described earlier, to do telemedicine. Prior to that, the nurses were doing home visits. It's very expensive for a nurse to do that. It takes hours to do, and they can only do that usually right after a hospital event to make sure the patient, knows how to live well, take care of themselves, or have everything that they need to recover so they don't end up going back to the hospital. So the value proposition there is pretty clear. The cost of a nurse visit is way higher than that nurse also training the patient to use telemedicine. And if you equip the patient's home with some of the monitoring devices as well, then it becomes an automatic alert for doctors to provide that intervention. I think the comment on the cost would be high, obviously there are new resources involving technology and training and equipping the whole workforce to do that. Sounds like it's a huge effort, huge programming, it would be very expensive. Well, the fact is it's already being done, but I'd say albeit policy. They're doing SMS, they're doing phone calls, they are doing faxes still. So you're just communicating completely ineffectively and probably out of HIPAA, and a lot of health professionals do, because how else are you going to get to the patient? You really just need to get this communication out. So I think the cost component, if you're on the policy side doing all these calculations, putting all the people and resources and programming, that becomes a huge number. But if you look at, what is already being done? Well, what is that incremental training that's needed? I think you'll find that those numbers are a lot smaller than pre-pandemic costs. And I think if you even look at the cost of number of hospital admissions, that could be reduced. I mean, in our first 8 months, we saw a $5 million reduction in costs just by providing the right intervention at the right time, patient education. I mean, everything you would do for intervention. And that alone could pay for everything you ever need for technology on the payer side, on the Medicare side. So I definitely think the adoption has happened. That's probably lowered a lot of the training costs, a lot of the even marketing costs on what is telehealth. Everyone knows what that is already. Everyone's already used it. So I think now is actually the perfect time to really look at full Medicare adoption of telehealth. And many Medicare payers have already been doing that. And I think if there's more concerted effort on, the playbook. I mean, there's still a lot of confusion on payment and telehealth and remote monitoring. And then what happens post-pandemic, and the rules have just changed, as of June 2021, there's some more new rules coming. There's a lot of confusion there. So I think a concerted effort on what does it mean? How does everybody get paid? Which of these policy relaxations will stay, and how would it be different? And I think clarity on that would be extremely helpful. Adoption, it's already there. And I think we can just streamline what's already happening, obviously make it adhere to policy changes. And I think another component is really tracking those cost savings. I think we're not doing enough to track the cost savings. I think it's enormous in terms of productivity. Pre-pandemic, we were at probably one nurse serving about 150 patients. Now we can do one nurse for 5,000 patients. So imagine at that scale, you train a patient, they know how to care for themselves. I mean, it's a no-brainer how you can scale with digital interventions.
Great. Thanks so much. And I think I agree with you 100% on the operations side. One of the biggest challenges prior to the pandemic was just we had, even our Medicaid program was covering. So we had a lot of coverage, but there was heterogeneity in the coverage. So when I order an MRI for a patient, I may or may not know whether they're covered, but I know it's medically necessary. And so, but if I'm telling a patient to follow up as a video visit, and they may get stuck with a full bill because their insurance is not covering it. That's going to make me feel bad. And a lot of providers felt that way too. So they would rather just not do it than deal with the fragmentation in insurance. And I think that if post-pandemic, I'm not exactly sure how everything's going to play out, but it really needs to be standard. Otherwise, you'll just get you'll go back to that kind of resistance to change. And you just don't want to get patients stuck with surprise bills. So Jamey, I want to take that, ask the same question to you. And I'm going to ask, I'm the head of CMS, like how can you tell me that healthcare costs are not going to go up if you are reducing the barrier to entry for these patients?
Chad, I love this question, right? Because anytime someone brings it up to me, it's like, it's 7:15 in the morning here on the West Coast and you've got me all fired up. You just gave me my coffee. So you cannot, what you're talking about is akin to rationing healthcare here in the United States. And there's so much false attribution error with, that number and being like, oh, well, costs are going to go up because we're going to increase access. Absolutely not, right? You want people to have access to healthcare early and often. You want them to be thinking about preventive care. You want them thinking about how to keep themselves healthier, because what we end up with down the road is people deferring their healthcare. And once they defer their healthcare, what do? We get a lot more acute conditions. We get a lot more people with chronic conditions, right? That helps, that we need Ming's company for, right? It's patently false. Because people it's one number. Yes, healthcare costs are going to go up, but we're increasing people's coverage. We're making the population healthier. We're allowing people to live longer. And as a natural basis, healthcare costs may go up overall, right? As the population increases and the population ages, healthcare costs are going to go up. But the real question is, do we want to be spending and Chad, you actually might know the statistic off the top of your head. I don't, but how much of our healthcare dollar is spent on the last X months of life, right? Yeah. We can avoid spending those healthcare dollars, extend people's life, improve their quality of life by allowing them to have easy access to healthcare. It's akin to telling people, well, we're going to start rationing food and not give people enough access to food because, we're worried about the cost of food. It doesn't make any sense.
Absolutely. And there's a lot of data on, deferring care. And I mean, one of the best examples would be, and this is mostly in the uninsured space, or the insurance space, but people will wait to get you see at age 65, you see a surge in people getting knee surgeries because they go years and years and years with pain and using medications and emergency room visits and stuff before they get to the Medicare, and they're Medicare eligible at age 65, and then they end up getting the surgery and they're much better off. So I think that deferred care, and then by then they may be getting a surgery that's much more complicated because they waited too long. So deferred care definitely leads to more advanced disease. And I think I do completely agree with you on that. Ming, you have to convince, you said China's a single payer, for the most part. So it's, you have to convince the government to make a big bet that healthcare spending is going to go down with your company.
Okay.
How'd you
Actually, we don't do that because government realized that already. You know what? Previously, before last year, the telemedicine cannot be covered by the government insurance. Okay, but from the early of last year, the government, because of the COVID-19, gives the opportunity to the government. They realize, so the telemedicine can improve the efficiency. Is a very good supplementary supplement to the public, offline public hospital system. So that's why in last year, after several, a very big meeting, then the government announced the government insurance cover the telemedicine already. And in this year, more and more provinces go to the practical process. Then the good news is in this year, because our company has several, online, the internet hospital license. We set up several internet hospital already. We have license, and from this year, some of our online hospital can be reimbursed by the government insurance. This is a very good news. So in China, the situation is different. We we don't convince government to do that. They already did.
Great. That's great to hear. So I'm going to switch gears a little bit and talk about access. And so I know that healthcare disparities is a big problem in the United States. I'm sure it's a big problem in China as well. Digital technologies have a huge ability to reduce healthcare disparities, provide access to care in rural areas that need it, that patients are traveling hours to see a specialist or to get even basic care needs covered. So certainly digital technologies have the ability to do that, but you have to be able to access digital technologies to be able to get greater access. So I want to kind of go around the panel and ask, like, how does your company and how have other companies that you know of gone towards that access issue in rural areas and then also in urban areas where there's low income and then also for patients that are older that have lower health literacy. So Ming, I wanted to start with you. I know that there's a lot of areas in China that are rural. I don't know what the broadband access is across the country, but how about that? And also with health literacy for people that can't use those types of technology. How's your company done that? Other companies that you know have done that?
Okay, actually, it's a dilemma. Okay, so two dimensions. The first dimension is distance. I mean, the rural area. I mean, it's a dilemma. Means because it's very far from the city. That means the resource. I mean, the medical resource is very limited. So very few doctor. Very few hospital, very few doctor. So their demand cannot be covered very good. So which means they need telemedicine more than a population in cities. Okay, but the problem is, as you mentioned, because of the technology or something like that. But for example, because it's too far, that's why the data transition speed or resource is also limited. So, but if we want to, diagnose, or if our doctor want to diagnose or give them some consultation or something like that, we need the infrastructure. Okay, so give you some data about that. According to our company, every year we deliver medical service to we deliver over 150 million times medical service to people, but only 10% of them a video consultation. 90% consultation, I mean, can well be done by word because of the data transition. Okay, so we believe across with the growth of the technology, for example, 5G or something like that, this better technology can well be implemented. Then this kind of dilemma will be solved as well. I mean, this is the first dimension. I mean, the distance. Second thing, second thing is about age and habit. As you mentioned, I mean, the older people has very little habit to use the technology, even use a mobile phone. Okay, this is not an issue in China already, because we have to thank, for example, like Alibaba or like Tencent, because this kind of company, I mean, the older people are a lot of the opportunity to use the mobile phone and use a WeChat. I mean, the instant message. And for example, my father, actually my daddy is around the 70s, but 10 years ago, he had a great habit to use the e-commerce. Okay, and he used the instant message like WeChat to communicate with his friends everywhere. So this kind of basic infrastructure and educate the old people in China. So this is not an issue. Okay, so in sum, I think with the growth of technology and infrastructure, I mean, the dilemma, like you mentioned, the rural areas will be resolved in the future. Yeah.
Great. Jamey, do you want to talk a bit about access, rural areas, health literacy, underserved?
Yeah, sure. I mean, that's the core of kind of what we do as a business. And I was actually on a talk with the UCSF Health Hub yesterday, and Daniel Kraft was on there, and he was talking about digital determinants of health. And he almost had like Maslow's hierarchy on a chart, and at the bottom of the chart were, Wi-Fi and broadband access. And those things are critically important. And one of the things that we need to keep in mind as we build out what are the digital front doors to the healthcare system is the fact that we can't embed a lot of the bias that's already built into our in-person healthcare system into that system, right? And an example of that is, and there have been studies that have been done on this, is that if you take the data that's in the current system, it's automatically biased. And if we put that into an AI, then the AI is going to be biased because it's getting biased data. So we need to make sure that we're being very thoughtful in terms of the digital health tools that we're building to make sure that they don't retain the same biases, and then they can actually level the playing field as we start to move to digital health, as opposed to creating what is a larger digital divide. So the USDA also has been working on broadband access issues in this country and doing broadband grants. There are telehealth resource centers now in almost every state that are working on making sure that rural areas have access to broadband. I think if you take a look at smartphone penetration, it's much higher than it's ever been before. I think 81% of the US population now has a smartphone. So from that perspective, I think we are doing great work in terms of advancing access. But clearly the regulatory environment and practicing across state lines and those types of things still need to be able to support that environment moving forward. Clearly what we saw during COVID, right, was providers and patients alike building muscle memory with digital health tools and realizing that they were a more efficient, more cost-effective way to actually, receive what I would call healthcare at the lower acuity levels. But there's still a lot of work that needs to be done there, and it needs to be done around not only health literacy, but digital literacy. We're seeing the evolution from a health literacy standpoint of health coaches. There have been a number of companies that have come up to help advise people, right? Like, what do you do, Chad, when you initially go into, the doctor and they say, oh, you have such and such? You call your friend who's a doctor who can help advise you, who's your trusted, healthcare advisor. I think it'd be great if everyone in the country had access to a trusted healthcare advisor who could be that third party, making sure that they're making, good decisions when it comes to their own healthcare from a health coaching standpoint as well. So I think we're going to see further evolution of those types of businesses, care concierges who help you navigate the healthcare system and help you handle some of those more sophisticated healthcare issues, and how to get a proper read of your MRI, et cetera, et cetera, et cetera. So I think there's still a lot of work to be done, but I'm seeing a lot of good progress there, in my view, with some of the new businesses that are being started to help solve these and address these issues.
Jamey, that's a really interesting idea. Those healthcare coaches and even the concierge docs could, with telemedicine, can actually join the visit and could actually hear firsthand from the specialist about what the care is, and then help translate that if that's needed. I think that's a really cool idea and one of the innovations with telemedicine. Ting, just want to turn to you. So this obviously is a big issue, and I'm sure it affects the expansion efforts and so forth. So rural areas, older patients, and disparities.
Yeah. And as you know, we work across the world, about 25 countries, and some places are in kind of like, think of Village of Africa. They have dirt, but they have some connectivity. And I think, that was one of the first problems we had to solve as a technology company. How do we deal with places with no internet? I think the worst situation is intermittent internet, where you have it. Sometimes it shows a little E or 1 or whatever number, and then it disappears. So we tweaked or focused on our technology part to deal with all of those situations so that anybody with any connectivity can use it. And obviously, in order for a full telemedicine consult, eventually, even if you have all of the data collected on the phone, it needs to be transmitted. And I think that's the other portion. And a lot of times we're solving that by either it's a health worker who goes to the patient's home to help with that process so that they can collect the information. They also do the coaching component. They also bring in the medication. So they do the intervention part, and they're the connector to a doctor literally by bringing their phone to another place that have connectivity.
Okay.
And that works fine, especially for some of the chronic conditions. Obviously nothing like, hit in the head, you have to go to the hospital. That's not where telemedicine really lies. But, in preventative care, screening, chronic conditions, follow-up. So that's very effective in terms of providing telemedicine that way. And then on the other hand, as Jamey said, huge adoption of smartphones. And even if we look at it, I think the data I have is just before the pandemic, a little before that, and then comparing number of patients who are accessing websites through smartphones versus computer. It's way higher. It's like 80%, 90%, which is a surprise to me. And this is it's the Medicare population, 65 plus years old are using their smartphone more than they're using computers. They're using it like a traditional phone, and many of them are replacing their, normal phones in the houses. So I think we're seeing a growing more than 50% and still increasing population that's going to have smartphones because, they need it for Facebook, WhatsApp, talk to their grandparents. So that adoption is happening with or without the healthcare components. So then we have the training component that would be not as difficult for those that already have a smartphone. That means they have Wi-Fi. Then the third category, one is they don't have anything at all. You use a health worker to try to facilitate that. And then the second, they have everything. It's all good, easy to do. Third population would be the one where a health worker won't be able to intervene and they don't have a device, they don't have Wi-Fi, looking at Medicaid or even some that are homeless or migrant. So for them, the intervention would be literally to send them a tablet, tell them where to get Wi-Fi, set them up, and then train them on how to do that. Tablets could be as low as $50. And if you have Wi-Fi, which you could have access in public libraries, clinics, hospitals, all have Wi-Fi. Another intervention we do is have the patient go to their, many of them have mental health issues, which is another very vulnerable population where telehealth could help a lot. They go to their mental health session for coaching, and that's where they have Wi-Fi, and they'll do the full assessment and use that mental health facility as sort of like a satellite clinic site to communicate with their primary care doctor or a specialist. So there are many ways, what I call connect the dots, from where the patient is, find out what equipment they need and what health professional they need. And even all of this, a home visit, it's still cheaper than waiting on them to go into the hospital. Because once that happens and there's no intervention, it's going to be a repeated event. The root cause of their health hasn't been addressed during those 364 days where bad things happen and they end up in a hospital. And another really important point is we actually have more than enough data to look at a lot of the events that could be prevented. And with the Medicare providers I work with, we can look at the data and predict certain patients also based on their socioeconomic status, based on whether they have a smartphone or not, to determine the best intervention and measure that prevention could happen, and also at lower costs. So I think a lot of the hurdles have been resolving itself, and some of the edge cases are becoming smaller in terms of population with edge cases, and there are already solutions for those as well.
That's great. Thank you for sharing that. So I'm going to switch gears. We have two more topics we want to cover. Wanted to cover quality of care, then also talk a little bit about the future. So let's start talking about quality of care first. Quality of care, once you've accessed the visit, once you have that access is important to consider too. So the quality, there's a survey that was done by our colleagues at University of Michigan who surveyed adults and found that 67% of adults, these were adults aged 50 to 80, felt that the quality of care through telemedicine wasn't the same as in person. Now, that may sound different than other satisfaction surveys that you hear because patients are usually satisfied. But if you compare satisfaction surveys with telemedicine, most people will give high satisfaction to healthcare in general. So if you compare those to in-person visits, they'll say high rates of satisfaction as well. So this was a pretty striking statistic. They were comparing in-person encounters to telemedicine, and 2 out of 3 people felt like the quality of care wasn't the same. And I think there's a lot of room to grow in this area. And I actually don't take that as a discouraging comment. I actually think that shows the opportunities to improve the transmission of care through telemedicine. And so I wanted to ask everyone, what opportunities do digital health have, particularly video consultations, that can help improve the care experience and potentially make it better than in person? And maybe that's stuff that's happening now, but also what else could there be in the future that could help improve that care experience for patients? I want to start with Ting and then go to Jamey and then Ming. So Ting.
Yeah, I think, and we've done a number of research on that as well. A lot of times when telemedicine doesn't satisfy a patient is because their issue couldn't be resolved. If we look at, for example, the Teledoc model, there's a list of issues they can resolve. If you're a patient that didn't read that really long list and you call and they say, I'm sorry, you'd have to, call your primary care doctor, then my need is not filled. I'm going to say I'm not satisfied. So I think, certainly there's one reason, maybe the mismatch of expectations. And then the second, let's say the telemedicine call is with the primary care doctor. That doctor, should know everything about me and know what to do. I think in those cases, need may not be satisfied because your result was, well, we can't do anything unless we have your lab test. Could you come in and get a lab test or do an MRI or something like that? So that would be another reason whereby the doctor doesn't have all that they need to recommend the next step or changes in treatment. So that goes into, I say, lack of information, which can be supplemented. They are literally like Uber for lab services, where some, nurse will come and collect your blood sample and send it out. And there are many, many services and more emerging like that could supplement that. But even, if all those pieces exist, the doctor side also need to think about it from a service perspective. What are all the information I would need in order to provide the right diagnosis and recommendation in a video call? Could I do that ahead of time? So when the patient joins, it would be a pleasant surprise. You already got my labs, you already got my information, and you're going to change my medication and call into the pharmacy. Sure. I think on that level of satisfaction, a lot of times the doctor is so inundated and they got on a video call, they just want to answer questions. A lot of times the whole service aspect isn't designed into the flow. It's not the doctor's job to do that at all. And there's a lot of missing information in terms of what services are available. How do you actually structure the highest experience telemedicine call? It's always been thought of, I answer the call, you hang up, and hopefully you give me a good rating. But when more and more of these happen, especially when we care for not just the episodic problems, not like my head hurts, but my heart is palpitating, I have heart disease, and I have history of these other diseases. What can be done? I think we're at the level where more of those could actually be treated remotely, especially in follow-up call with primary care doctors. But primary care doctors are not looking at the full experience, not their job too. So I think there's a lot of opportunities there for improvement. But I think overall, it can all be done. And again, the whole quality, the whole customer journey, customer experience aspect isn't something that is part of the medical professionals training. And I think the way professional service patients have changed, and I think we can do a lot more there, looking at, more of a consumer experience perspective. Because even some of the seniors, at least, so for example, China, India, the doctor is like the god. We're in the US, the doctor is a professional that's going to provide service to the patient. So I think there's also that different lens of expectations.
Great.
But I think there's a lot of potential. Yeah.
It's great to hear. I actually think my biggest lesson I've learned is just to have everything ready for the appointment, because, when you're in the office and you have to look up a lab or something, it's fine. You're in front of the patient. They see what you're doing. But when you're doing a video consultation, if I'm looking up a lab, this is a conversation I'm having with the patient. So it really does affect their experience. I've talked to a lot of patients. I've talked to people that were, that have had that experience, and that's a big thing for sure. So Jamey, even if satisfaction is the same, like how do we get above that metric of improving quality of care, making virtual care even a greater experience for the patient than in-person care?
Yeah, so I think there's a few things, and I thought Ting's answer was phenomenal, talking about expectations and kind of the human side, of the business, and you talking about preparation. The fact of the matter is, our medical workforce in the country has not been trained for telemedicine, right? They've been trained to put in-person visits, hands-on body, and now there's a big movement, right, in medical schools to begin talking about website manner and what we would call a new type of physical exam, right, where there's a lot that you can do as a doctor where instead of you palpitating, you say, hey, push right here. How does that make you feel? It's a much more communication driven patient exam than even you might have had before. So when that training's happening, we have a lot of doctors who just aren't skilled. It's a skill doing a visit where you're making sure that, your computer's like not here and you're looking at somebody's chest, or that you have good lighting, all those different types of things that it takes to really set up what is a good video encounter, or to have a proper email exchange with someone, or to do, an over the phone Q&A session. Those are skills, and we need to skill our workforce and our clinical teams, so that they can do these digital health visits. So I think that's one thing. I think another thing quality wise is that clearly quality can improve with telemedicine. It's much easier to do discharge follow-up with a phone or a video call, much easier to do medication adherence and double check those types of things afterwards. And to be able to say, oh, you came into the ER today, I'd like to set up a call with you tomorrow just to see how that wound's healing, right? And that little touch point of either emailing a picture of the wound or being able to get on with that patient. And, it shows that there is a continuum of care that's supporting you much more than just an episodic visit. And I think a lot of the dissatisfaction in telemedicine is actually centered around episodic visits, as opposed to using these digital health tools to build a relationship with the provider who already has your longitudinal patient record, who, we're big believers at ClouDr that local healthcare wins, right? That the people who you already have your relationship with it should be enabled with digital health tools, because that's going to improve the level of the experience. And if you take a look at places like Kaiser or the VA, which are closed systems, they do well north of 50% of their visits using digital health tools, right? And it's taken a while for community medicine to kind of catch up with what Kaiser and the VA have been doing from that standpoint. It's more efficient. It saves the patient travel time. It's a much more satisfying experience to be seen in your home than to have to go wait in a waiting room for what is a short visit. It saves cost in terms of parking and those types of things. But it's really about setting up what is an integrated continuum of care. And when you've done that and it's enabled with digital health tools, it's a higher quality experience.
Great. Ming, any comments on that in terms of how to improve the quality of experience that patients have through telemedicine?
Okay, so basically the situation is different here. First, our government have the policy. I mean, they this policy means they need the doctor have to pass the examinations like a test. They define the doctor for several levels. Before the middle to senior level, for the middle to senior level, doctor can be approved to the telemedicine. So this is the first thing, because the policy guarantee the average quality in telemedicine is beyond the average quality for offline medical service. This is the first thing. Second, as I mentioned before, 45% expense is covered by ourselves, which means if the quality cannot make patient satisfactory, we will not pay for that. So the system is different. So these two things can help us improve, improve the medical quality service. Yeah.
Great. So we're getting ready to close up. I have one more question for each one of the panelists, and if anyone else has another question, please feel free to send it through the Q&A. So Ming, this is a question that often comes up. I'm sure you've been asked this many times. What do you see as the future of digital telehealth at two different time points? What do you think the future will be in 5 years? And what do you think the future is going to look like in 10 years for digital health? I'll ask Ming, we'll go to Jamey, and then we'll have Ting close out.
Wow. Okay. For startup, it's very difficult to foresee what will happen 10 years. In 10 years, it's very difficult. Okay, but we will try. Another thing is, the history of our company is only 7 years. But your question, you ask me, well, 10 years later, what will happen? Okay, it's really challenging. Okay, first, we believe in the next 5 years, several trends is very obvious. First, I think more and more online hospitals in China will appear, which means more and more hospital doctor will join this game, deliver the online service to patient, to give them the instant service to patient in cities and urbans. This is the first trend. Second, as I mentioned, the government insurance will cover the online medical service. We believe, which means more and more patients will pick up this kind of service because of the reimbursement and convenience. This is the second thing. The third, now the telemedicine, most of telemedicine focus on the oncology and chronic condition. But we believe in the next 5 years, more and more area will be involved. In the telemedicine. For example, the dental, for example, the diagnosis, something like that. Okay, so this is a trend we think will happen in the next 5 years. Okay, but the most difficult part is coming. What will happen in 10 years? Okay, we believe because now, the Western country like US and European, the system is more developed. The medical system is more developed than in China. It's very obvious. So which means, the situation today in US will be the future in China 10 years later. So this is my answer for this challenge question.
I see.
Okay.
Okay. Well, thanks a lot, Ming. I appreciate that. I do want to just ask one follow-up question to you before we go on to Jamey about that with the same question, because it was one that came from the audience. It was specifically about dental specialty. How do you think that dental specialty is going to be involved in digital health? I'm not even quite sure how much it's involved now, but how do you think it'll be involved in the next couple of years?
Me?
Yeah, Ming. Yeah.
Okay.
Because you mentioned dental, so I was curious.
Yeah. I think now, very few telemedicine involved the dental area. It's very few because they need picture, they need some diagnosis, but we cannot do that online. So that's why we believe now. That's why now they have the percentage is very low. But probably, according to the growth of the technology, several years later, for example, we have the better technology for video. Then we can do some remote diagnosis, and which means the patient can get the diagnosis and the solution at home, and then go to the hospital, do some surgery or something like that to improve the efficiency. Yeah, this is my idea.
Great. Thanks a lot, Ming. So Jamey, 2 time points, 5 years, 10 years. Where do you think digital health is going to be in the United States?
Yeah, I mean, from our standpoint, I think over that time gradient, we're just going to see more and more care pushed to alternative environments than the bricks and mortar that health systems have built out. It's going to be pushed to home, it's going to be pushed to work. And what we're talking about at UpHealth these days is what we're calling the establishment of digitally enabled care communities. So one of the things that digital health can really do is break down the barriers between health systems, between nations, and all these different types of things to really allow you to collaborate and hook together what previously were disparate parts of the care continuum. So when it comes to things like social determinants of health, being able to figure out how you're going to treat one of the homeless population, tie them into a health system, tie them into a shelter, tie them into mobile support resources, and to be able to surround a patient, no matter what their challenges are, with the exact care team that they should have, right? And the exact support network that they should have. And we refer to that as a precision care team. So I think over time, that for me is an exciting part of where things could go, is that you could have a patient who has, 3 comorbidities and, congestive heart failure, diabetes, and X, and then surround them with the exact people that they need to provide that treatment. And that might be a cardiologist from NYU. It might be a dietitian from the University of Michigan. It might be support services from a case manager at a different place. But these are the people who have the expertise for that specific patient's needs. And I think that's where things will get really exciting. And 10 years from now, I just think, the home is really going to become a primary care zone where you have all the digital tools that you need in a kit. And your initial thing that you're going to do is go grab your kit, hook up to the system, and then have a doctor come in and remotely diagnose you, whether it's your own primary care physician or a health system. Remote patient monitoring tools are moving forward at a very accelerated pace. You have tools right now like TytoCare, et cetera. And the issue with them right now is they're just too expensive for the layperson to have in their home. But as technology costs drop, as we've seen, Moore's law and all that great stuff happen, right? So as those devices become more affordable, and we're starting to see lower cost diagnostic devices come into play. Scanadu was working on something for a little while, and a bunch of other companies were trying to figure out how to build what is the StarTech tricorder. As those things start to come to fruition, I just think more and more is going to be done in the home. In 10 years from now, the home might be your primary venue for healthcare.
That's amazing. That's a great vision, Jamey. I remember, it wasn't too long ago where people were saying, had to go into a bank to deposit a check. And now it's sort of the 90% of the banking that you do is at home. And there's actually very little reason to actually go into a facility like that. And I think that your vision about how
it's a perfect analogy.
Yeah, how virtual care, will eventually reach a stage where people are going to be like, wait, what? When I was your age, I used to have to go in to follow up on a CT scan or a lab test just for 15 minutes. I used to have to drive in to hear that result. So I think that's a great vision, Jamey. Ting, how about you? Where do you see not just your company, but just also digital health in the United States at 5 years, short term, and then 10 years?
Yeah, I certainly second what Ming and Jamey said. In the 5 years, we're going to have more of what we're seeing, given I think very soon policies will be clear. All of the restrictions, I think, would still be somewhat lifted with some more perimeters around it. So I definitely see the ability to have virtual doctors of the best fit for that patient from anywhere, regardless of which state, hopefully within the 5 years timeframe. I certainly think there's a huge role in the data and AI play. There's a lot of data we are collecting. I think even through telemedicine, we are getting more data than we can possibly get just in the clinic setting. There's data from the environment, patient's movement, patient's heart rate over time. There's a lot more data that can come into part of the picture, the data set, for helping to diagnose that patient. And I think that preemptive part is really, really important as well. I mean, we just look at the data we have now, we can predict certain patient that is likely to come in the next 30 days. And I know we already have that ability. I think by having more televisits, telehealth interventions, we're going to have richer data set that can help us better predict even, 60 days, 90 days, and then deliver the interventions remotely or even in-person visits. also see a lot of training programs would happen in terms of how do we actually do telehealth from a consumer experience perspective. I think all of that can be done in the next 5 years. Now, in the 10-year horizon, I think there'll be more hardware. So a lot of hardware, and the reason why 10 years, because it just takes time for newer hardware to be 510(k) approved, to then get reimbursement, to trial and pilot. Hardware just takes that much longer. So in the 10-year horizon, I think we can definitely see a lot more hardware that are lower cost. I think also hardware that are embedded in the homes, hardware that you are wearing, hardware that is just ambient, is part of the environment that is detecting your gait, movement, heart rate, everything that you would otherwise have to do in a physical doctor's hospital or hospital. And I think there's going to be also a lot of help for doctors to collaborate. And, you know, with more data, it becomes humanly challenging to look at all the data we have, you know, in order to figure out, well, what am I supposed to do with this patient? I think there'll be a lot of AI assisted help to help the primary care doctor incorporate the knowledge and advice from specialists of every kind, and really thinking of it, you know, like a super doctor that's got all the brains of the best doctors in the world to help make that decision and what to do. And I think also on the intervention side, our health workers, home visit nurses would also be better equipped with knowledge and devices to be able to care for that patient. Possibly, I know it's happening in Singapore and other places, there could be a nurse bot, the robot that shows up, greets you, brings you breakfast and your pills, make sure you take the medication, does a complete examination, just do the video, call the doctor if, you know, if the doctor's is needed. I definitely see that as possible happening in Japan, Singapore, parts of Asia. I think we want to look at what's going to happen in 5-10 years. We could certainly look at other countries that have maybe less regulations to look at, you know, how are they able to leapfrog, because there are less resources, you know, potentially less overall funding in the market. But I think, you know, even in some of the emerging countries I work with, they've adopted telemedicine long before we have in the US. I think, you know, we shouldn't be all looking at, well, what is the, you know, US doing, but really how are other countries leapfrogging already, and what could we take from there, and what is it we have to do on the policy side, because it has been a delay in technology adoption, especially in healthcare. But I think we're at the point of, let's look around the world. The pandemic happened and we lifted the rules and nothing disastrous happened. In fact, nobody, you know, in fact, we found a lot of benefits in terms of how we can provide better healthcare at lower cost, and that people actually want and are happy with. So I think by 10 years, you know, it's you know, it's already happening in some other places. And I think we can collaboratively look at what we can do together to really be the best possible in the next short term and long term.
Yeah, thanks so much for that answer. I think it's funny that you say to kind of look elsewhere, and then Ming says look to the US. So I mean, I think it really just proves the point that, you know, every country in the world is, you know, experiencing this, and this is relatively new, at least to some degree in most countries, and we could really learn from each other. There's some pros and some, you know, pros and weaknesses in other countries and strengths in other countries that we can kind of take together to learn from. Because I think, you know, this we're going to be closing out this forum, and I think that you know, it was great. It was great having you all here. We were able to really run the spectrum of issues related to digital health. And I think that while we can't all predict what's going to happen in the next 5 years or 10 years, no one could really have predicted the virus would create this amazing catalyst for telemedicine. We're not sure what's going to happen, but these issues of access, these issues of healthcare spending, these issues of quality, these issues of patient experience, which we all discussed during this session, are going to continue to be important things that grapple policymakers, health systems, physicians, and patients too. So I think that thank you so much for your insights, Ting, Ming, and Jamey, for you know, I know it wasn't easy coming here on a Saturday morning, especially with the time zone changes, but I really appreciate your time here. And also want to just thank the Michigan China Forum, all the coordinators and students that helped put this together. I know it's not an easy task, but I thank you for the opportunity to speak and also to help moderate the panel session. So I'll turn it over to Michigan China Forum if you have any additional comments.
Yeah, thank you, everyone. Thank you, Dr. Ellimoottil. Sorry for the mess earlier, and it was such a insightful and thought-inspiring conversation, and I learned a lot as a pre-health track student. And I hope all my audiences are getting a lot from the all these expertise that you delivered during this conversation. And so yeah, I just want to have you guys know that we actually have 107 more than 170,000 viewers on the other platform back to China and here. So yeah, that was a really great success, and I'm really happy. I hope you guys enjoy this conversation as well. And before you guys leave, I would love to all my audiences, it would be really appreciated if you can scan. Thank you for your participation, but it would be really appreciated if you can take a few moments to scan this QR code. Just give us some feedbacks about the event today, and let us know what you guys think about the topics and the overall quality of the event. And if possible, feel free to scan the other QR code to follow us on the website and other social medias as well. And thank you very much for all your participations. And I've definitely learned a lot, and I see the optimistic future of the digital health technologies and the healthcare industries. So yeah, thank you very much for your being here, and I hope everyone have a good rest of your day. Have a good night, good morning, or good afternoon. It is a great success. I really appreciate that. Words can't really describe how much I appreciate all of the contributions from you. Thank you.
Very
Thank you
much
for having us.
Thank you.
Bye.
Bye.